Good morning. Today's topic is shoulder dislocation. This is a commonly dislocated joint, very often seen in athletes or players. This is the shoulder is the most unstable large joint. There is excessive mobility at the expense of stability. The shoulder joint gives a maximum range of movement. Forward flexion is about 180 degree. Abduction is almost the same. Rotation plus circumduction, that is when you associate the scapulothoracic movement with this. The range of movement is much more than in knee joint or hip joint, though the direction of movement is a multidirectional movement in hip joint is also there, but the range of movement is much less. You can see the glenoid surface is almost flat and the humeral surface is almost rounded. Yeah. Not like hip joint. There the femoral head is also round and the acetabulum is a cavity. The glenoid is a very shallow cavity. So it's the most unstable large joint. So its stability depends on the surrounding muscles and the strong capsules and ligaments. So the glenohumeral instability is the inability to maintain the humeral head in the glenoid fossa. You can very well see this is the glenoid fossa and the humeral head has come out of this and lying here. This is a coracoid process and this is the clavicle. These are the ribs. The humeral head has come down to lie just below the coracoid process. This is an anterior dislocation of shoulder. The reasons for instability are once again the shallow glenoid, extraordinary range of movement, vulnerability of upper limb to injury, and the underlying conditions as for example ligament laxity. There are some persons who suffer from excessive ligamentous laxity such as maybe Ehlers-Danlos syndrome, Marfan syndrome. They have excessive ligament laxity. The directions of instability, that is the directions of dislocation. After dislocation, the humeral head goes, if it goes anteriorly, this is called an anterior dislocation of shoulder. This is most common, maybe 97 to 99% of dislocations are anterior dislocations. And most commonly, the humeral head after dislocation comes to lie under the coracoid process. It is called a subcoracoid dislocation. Well, subglenoid is rare. Subclavicular is also extremely uncommon. And intrathoracic, well, it needs a very, very high energy injury. It's extremely uncommon. There is another variety that is a posterior dislocation when the humeral head goes posteriorly. Though it is said 3% of recurrent dislocations, maybe the real incidence might be much less. This is commonly associated with seizures as we see in grand mal epilepsy or following an electric shock or a fall on flexed and adducted arm. There could be inferior subluxation or inferior dislocation. Superior is extremely uncommon because of the presence of acromion process on the top, and bilateral, that is also extremely uncommon. So what is the pathoanatomy? How and why it occurs? During a severe trauma, there occurs stretching and tearing of capsule, avulsions of glenohumeral ligaments, usually off the glenoid. You see, these are the condensations of capsular fibers. They may get torn, or the labral injury. The deficit of glenoid, as it's very shallow, this is somewhat tried to make up body by formation of a labrum, which is a cartilage type of tissue at the edge of the glenoid. Of course, labrum is also present in the acetabulum. Labral injury, when the labrum gets torn due to violent movement of humeral head anteriorly, the labrum gets torn from the bony glenoid. That is called a Bankart lesion. It goes by the name of a famous surgeon, Bankart lesion. Or there could be a impression fracture posteriorly, posterior part of the humeral head. That is, when it becomes dislocated, there is a impression fracture at the posterior humeral head. That is called a Hill-Sachs lesion or a Hill-Sachs lesion. There could be associated rotator cuff tears. This is the classical appearance of a anterior dislocation of the shoulder. The patient comes like this. This rounded contour of the shoulder, contour of the deltoid is lost. Here it's flat. The arm is apparently lengthened. Patient complains of severe pain here and is unable to move his shoulder. So this flattening of the contour of shoulder, this is most diagnostic. Of course, you will take a X-ray. This is a normal radiograph. Here you can see the glenoid is here. This is the glenoid, this is the humeral head, this is the acromion process, and this is the coracoid process. This is normally it lies like this. Due to violent trauma, this comes out of the socket and tends to lie here. Yes. After the dislocation, glenoid is here. This is completely out of the glenoid and lies below the coracoid process. This is the coracoid. This is the acromion process. This is the anterior dislocation of shoulder. It's an emergency. Pain relief is not possible till it is reduced, that is pushed back to the glenoid. It's an emergency. It should be reduced in less than 24 hours, or it becomes more difficult to reduce it by closed means. The patient is put under short anesthesia, then by some technical maneuvers, the humeral head is reduced or pushed back into the glenoid. Then, as the capsule and ligaments are torn, to give time for the capsule and ligaments to heal satisfactorily, the shoulder joint is immobilized. That is, the arm is strapped to the trunk for 3 weeks and rested in a collar and cuff sling. This is the method of reducing a shoulder dislocation. In cases of recurrent dislocations, patients can be very cooperative, and if he comes fresh within an hour, then maybe anesthesia is also not required. The surgeon pulls it, bringing it, and there is counter traction that is by a bed sheet here. She pulls the scapula towards her side, and this is counter traction, and this is the traction. Traction. When the head gets dislodged from its dislocated position, then by some maneuvers, this goes back to the shoulder joint itself, that is glenoid. This is another method. This goes by the name of Hippocrates Method. So you see, this is a very, very old method. When there are lack of assistants, the traction is put like this, and counter traction and the pressure over the humeral head is placed by the foot of the surgeon. He places his foot in the axilla that is near the humeral head, pushes it back, then it goes back. This is a classical Hippocrates method, rarely practiced these days. There are much safer techniques. This is another method, Stimpson's technique. If the patient can relax adequately, lies prone, one weight 5 to 10 pounds, 5 to 10 kg weight is hanging from here, which gives traction, and the scapula and on the glenoid is stabilized on the table. After maybe some simple maneuvers here, or maybe in some cases of recurrent dislocation, they may get spontaneously reduced. There are several other methods. This is a classical Kocher's technique. This is also very commonly done. There is a traction on this way. Then the next step is the humerus is externally rotated. Then it is adducted and internally rotated. The most important part is by this traction. When it gets dislodged from this dislocated position, it has got back only one place to go, that is its original home, that is to the glenoid. These steps occur automatically. One must follow the proper techniques and not to be very, very violent, because that may cause fracture of the neck of humerus, or in some cases there already had incomplete fracture of the glenoid. The X-ray has to be visualized accurately, or if there is incomplete fracture due to violent or vigorous manipulations, this fracture may turn it into a complete fracture and displacement. So one has to be very careful. What could be the complications of anterior shoulder dislocation? The early complications are damage to the axillary nerve, which supplies the deltoid. There could be damage to the axillary artery. So when a patient comes with anterior shoulder dislocation to casualty, the distal neurovascular status has to be checked properly. The ligaments may remain lax. There could be associated fractures, as I said, neck of humerus, or greater or lesser tuberosity. In many cases, we get associated fracture of the greater tuberosity of the humerus. But the good thing is when you reduce the dislocation, the greater tuberosity falls back to its own place. That does not require any extra treatment, either internal fixation or not. Hill-Sachs and Bankart's I mentioned. Well, this is a diagram, this is a humeral head, and this is the glenoid. This is the glenoid. This is shallow, and this is the cartilage sort of thing attached to the glenoid. This one. This is called the glenoid labrum. This remains fixed to this bony edge of the glenoid, but due to the violent trauma, what happens when the humeral head comes anteriorly, then labrum gets detached. This is what is called a Bankart lesion. This is a Bankart lesion. This is anterior glenohumeral ligament. This is, if you look at from this side, the end-on view of the glenoid, this is the labrum. This is the labrum. So it makes it weak. Through this weakness, the humeral head goes out. And this is what is a Hill-Sachs lesion. There is posterior part of the head. There is a bony impression defect as per the arrow. This is called a Hill-Sachs lesion. Commonest complications of anterior shoulder dislocation, the late, is a recurrent dislocation. That means repeated episodes of anterior shoulder dislocation. If it occurs more than 2 occasions, then the patient should undergo reconstructive operations for strengthening the shoulder so that the dislocation does not occur again. This is quite a common thing. One of the common reasons is if the primary dislocation event is not properly treated. This is one. There could be other reasons also. There could be inherent insufficiency of the capsule or the ligaments, makes it prone to develop recurrent dislocation. A recurrent dislocation is mostly anterior. Of course, there are situations of posterior dislocation. The coracoid lies anteriorly. So in this case, the humerus has gone posteriorly. This could be clinically, it looks like this. The same thing, the contour of the shoulder deltoid is lost. The humeral head can be seen lying posteriorly. This is a shoulder joint AP view, normal. This is, you look here, the humeral head lies posterior to the glenoid. This is a X-ray evidence of a posterior dislocation shoulder. It's like this. This is also a posterior dislocation of the shoulder. Recurrent anterior dislocation of the shoulder joint, the patient gives a history of repeated episodes of shoulder joint getting dislocated. As the number of episodes goes on increasing, the amount of trauma needed to dislocate the shoulder becomes much less. In some cases, at night, when the typical position is abduction and external rotation of the shoulder, abduction more than 90 degree, then external rotation of the shoulder, then the shoulder joint, the humeral head pops out. Maybe those who are having 10, 12 times of dislocation, they may have it during their sleep also. Requires minimal trauma. But most commonly, the trick to remember is when a cricket player, the bowler, goes to deliver the ball, his limb is like this, abduction, external rotation, then the shoulder joint pops out. This is the pathology of recurrent anterior dislocation of shoulder joint. What are the tests? If the humeral head, if the arm is pulled down, you can get a depression here. This is a sulcus test. You get a depression here. That denotes superior capsular laxity and the anterior glenohumeral joint laxity. Most important test is a apprehension test. For anterior dislocation shoulder in 90 degree abduction, elbow in 90 degree flexion, external rotation with anterior stress like this, the patient gets scared. Patient cries out because he knows that the shoulder is going to come out. The shoulder is going to be dislocated now. So he violently tries to stop the examiner. No, please don't do it, please don't do it. He feels that the humeral is going to come out. By this particular movement, 90 degree abduction, elbow in 90 degree flexion, forceful external rotation, maybe with some anterior stress. This is the apprehension test. This is always positive. Patient tries to resist it. This is the most important test, apprehension test. You may not get any other positive test for testing a recurrent anterior dislocation shoulder. I'm not talking about posterior because that is extremely uncommon. Apprehension or instability is produced. Now, how to treat these conditions? Of course, the more and more it gets dislocated, and its a main problem is with young athletes. There are 10, 12, 15 dislocation episodes. Each time the humeral head moves out of the glenoid, there occurs damage to the articular cartilage covering the humeral head. What will happen then if there is articular cartilage damage? That will lead to osteoarthrosis, degenerative arthritis of the shoulder joint at a very early age, say 30, 35 years. Of course, elderly people also come with one episode of anterior dislocation shoulder. They can be reduced easily. Usually recurrence rate is very low. Usually they don't recur. So this operations for recurrent anterior dislocations are applicable in cases of young active persons. There are several operations for this. There are about 250 types of operations being performed all over the world. So you understand there is a lot of controversy about which one is the best one. You'll be glad to know that Professor A.K. Shah was attached to NRS Medical College. I was very fortunate to attend one or two of his classes. After that, he retired. He did some pioneering work regarding recurrent anterior dislocation of shoulder. And his thesis and the papers came out in all the famous orthopedic books in the world. These are still mentioned, his operating techniques were still mentioned in all the major orthopedic books, Professor A.K. Saha. Now, coming back to the operative principles, the Bankart procedure is one of the very common things. This can be done either open technique or, as you know, arthroscopic techniques are very, very popular these days. Any joint pathology can be tackled by arthroscopy. All of you have heard about knee arthroscopy, shoulder arthroscopy. Yes, let me first talk to you about the open Bankart's procedure. This is tendon of the biceps. This is the anterior aspect. This is the coracoid process, tendon of the biceps. This is the anterior capsule and this is the subscapularis. Subscapularis is split. Then capsule is split in the same line. Then the glenoid is seen. This is the glenoid. And this is the capsule and the labrum at the same time. Three holes are, you can see the labrum and the capsule are detached from the glenoid edge. Three holes are made in the glenoid edge. Sutures are passed, and by these sutures, this capsule and the labrum is placed back and fixed to the glenoid. That is repair of the Bankart lesion. Then the capsule is closed again, subscapularis is closed again, and the patient is kept arm to chest strapping for 3 weeks. The same procedure can be done. This is the real technique. Sutures are being passed. Now the sutures will be tied. This is the open Bankart procedure. Now, along with the Bankart, there occurs double breasting or overlapping of the capsule. So this capsular laxity is controlled. So one layer of capsule is overlapped on the other layer and then sutured. So that makes the capsule tight. This is during the closure. This same procedure can be done arthroscopically. This modified Bankart procedure. This is another operation which is very, very popular these days. Anterior stabilization with associated glenoid deficiency. That is, after several episodes of dislocations, the anterior, the antero-inferior part of the glenoid becomes very shallow. What is being done? This coracoid process is osteotomized here. Then coracoid is brought down and placed on the glenoid edge and fixed with 2 screws. Look, this is the coracoid process. This is a coracoacromial ligament. These are coracoclavicular ligament, trapezoid and conoid. These ligaments are released. This ligament is also cut. Then this muscle remains there. Along with the muscles, this coracoid is cut here, osteotomized. Then this is coracobrachialis and short head of biceps. The musculocutaneous nerve is there. One has to be very, very gentle here. This is brought down here, and this bony block is placed here. This is the area through which the humeral head comes out. After several episodes, this area becomes destroyed and shallow. This bone block is placed here. So that gives a block to the anterior coming out of the humeral head. This is the osteotomy of the coracoid. Now, this coracoid process is the same steps. Subscapularis is split apart, capsule is rent. Then you can see nicely here, this bone block, this coracoid bone block is placed here. So, this part is deepened. So, when the humeral head tends to come out, this puts a block. This is a bony block fixed with 2 screws. And the coracobrachialis and shorted biceps are still there. So this is the most practical operation these days and very, very popular all over the world. This is called a latter jet procedure. Of course, this latter jet procedure and the Bankart's procedure, these two can be done through arthroscope. These are the portals through one perforation, one nick. Arthroscope is placed here through another nick. Maybe this light source is placed, and through other portals, instruments are put in. So these are the arthroscopic view. You can see the shallow area here. This labrum and capsule are detached. This is made raw. Then passing the sutures. Then sutures are tied. Everything is done arthroscopically. There are several advancements in this technology. So you do not need to use your hands to put the knots. These are placed in such a way that if you pull it, the knots are placed. These are all arthroscopic technique, arthroscopic Bankart repair. This latter jet also can be done arthroscopically. Thank you very much for your attention. That's all today.